Good afternoon, everybody. So I'm Raphael Thuillier. I work in Poitiers at the INSERM Unit 1082, and we work on ischemia reperfusion in organ transplantation. So I'll be changing the topic a little bit on a more practical point of view, perhaps, or more down-to-earth transplantation or organ of transplantation. So to set up the topic, if I point to it, maybe, or okay. So transplantation is, I used to say currently, but actually this has been lasting for quite a while now. It's facing a crisis in terms of organ shortage. About 2 to 3 years ago in 2015, what we used to say is that there was only one organ for every 4 patients on the waiting list. This is the numbers from the French directory in the kidney organ transplantation. However, this is a worldwide trend. And currently, we're quickly going to the point where it's one organ for 5 patients on the waiting list. So there's going to be a lot of patients on the waiting list waiting for an organ. And this pushes centers to search for new sources of organs. And this leads, the other way around, okay. This leads practitioners to extend the donor criteria acceptance. And one of the criteria, the new criteria that has been extended is age. You can see here that back at the end of the last century, the number of donors over 65 was very little, 5%. This has grown now to almost 30% and is still growing. Other criteria that have been extended is that we are now accepting organs from age donors over 50 with one or more comorbidity factors such as hypertension, diabetes, a history of cardiovascular disease, even a low level of renal failure for kidney transplantation because we just need organs that badly. And we are now reaching the point where more than half of the organs that are being transplanted are from these donors, what we call the marginal donor category. They're called marginal as a simplification for the fact that their organs are lower quality. We call it lower quality. Basically, they are much more sensitive to injury. They have been through a lot already. We're going to put them through transplantation. You'll see that it's not a minor stress. And they're more sensible, so they're more prone to have worse outcome than regular organs. So in terms of what stresses they are being subjected to, the first one is ischemia reperfusion in organ transport. So it starts at the donor level when obviously the organ is collected, flushed with a cold preservation solution, and then transported either as what we call static preservation, that is the organ sits in the liquid in the box for X amount of hours. Kidneys go from 18 to 36 hours, for instance. We also have machine perfusion, which perfuse the organ continuously with a cold preservation solution. However, it is generally deprived of oxygen and kept at 4 degrees for an extended period of time before reperfusion, when it is anastomosed into the recipient and brought back very rapidly to regular temperature and to oxygen and blood flow. So I will quickly go through that because the previous talk was very informative and much above what I can do here. But basically, during hypoxia and hypothermia, the mitochondria is obviously not going to have oxygen. The respiratory chain is not going to work. We saw that this is going to accumulate succinate. And in terms of the cell, that lack of ATP is going on the one hand to influence its pH. It's going to decrease the pH. And on the other is going to imbalance its ionic equilibrium between the outside and the inside of the cell. And this can lead to long-lasting problematics such as the influence of the membrane potential, increase of calcium inside the cell with all the different consequences in terms of structure. One of them is the activation of calcium-dependent proteases and the transformation of xanthine dehydrogenase into xanthine oxidase. Why is that last one being important? Because it's going to work during reperfusion to develop an excessive amount of reactive oxygen species. So at reperfusion, we're restoring O2 to a cell that has been subjected to a long period of cold ischemia. So a lot of that oxygen is unfortunately going to be used to be monoreduced into, and I'm sorry that I have to say that in my talk, to the reactive oxygen species, superoxide anion indeed, and actually during ischemia reperfusion injury, that the succinate going through the reverse electrotransfer seems to be one of the main source in the mitochondrial site of the superoxide anion production. It's also going to be, ROS are also going to be produced in the cytoplasm with that xanthine oxidase, which is going also to use oxygen and hypoxanthine to make xanthine and H2O2. I won't go into detail into the damage that ROS can cause to a cell, but in terms of the mitochondria itself, it can depolarize its membrane and open the presumably existing PTP and basically causing mitochondrial edema and mitochondrial destruction, leading to cellular destruction. Now, in terms of the broader scale of these consequences, and so we saw that during ischemia we have ionic imbalance, energy metabolism perturbation, loss of membrane integrity. There are some adaptative mechanisms, such as the HIF-1 alpha pathway, which we detailed, and it actually is associated with a better outcome for the cell in our setting. However, it brings the principle of time. That is, the HIF-1 alpha works very well if it is kept on for a longer period of time, whereas we are preserving organs for up to 18, 24, 36 hours long after that time of activation of HIF-1 alpha. So the cell can survive short periods of cold ischemia, but not longer period. This might be due to adaptative mechanisms. And during reperfusion, we saw that on the cellular level, we see oxygen toxicity, oxidative stress, and cell death. But this was signaled to the rest of the organism that something is wrong. Through the DAMP signaling pathway, we're going to see an immune response activation. This is going to be strengthened by the endothelial dysfunction and activation of the endothelium, which sits at the interface between the organ and the organism. And it's actually going to express the fixation sites for the immune cells. Now, normally, this is a good thing. Immune cells come around, clean up the mess, and you can regrow your tissue and have a perfectly healthy organ. Unfortunately, in transplantation, this is usually an organ coming from another place that is foreign, and having the immune system come over and destroy things is just not a good thing. Therefore, ischemia reperfusion is directly linked to clinical consequences in terms of transplantation with primary non-function, delayed graft function. This is short-term consequences. However, it is also linked to chronic dysfunction, such as the development of tissue fibrosis and loss of organ function and graft loss at the end. So what we do at the unit is study these stresses with the typical models in vitro and small animals. We also have the privilege to have access to the pig as a preclinical model, which allows us to access its organs in isolated perfused settings. The pig organs are very interesting because it's very close to the humans in terms of anatomy and size, and we can actually use the same device in terms of organ preservation that are used in the clinic. So it has a high level of translation to the clinic in terms of the findings that we develop on these models. One of the reasons is also at the kidney level. The pig kidney, is multipopular and multilobular, meaning that it requires a heightened level of networking in its vessels, the vessels being the first line of victim of ischemia reperfusion stress. This kind of organization, of higher organization, is common in higher mammals, but actually not in rodents, which makes it difficult to have direct conclusions from rodent model in organ transplantation. Now, this pig model, we now have it developed along several different pre-donation states. We have obviously warm ischemia just to increase the damage that the organ is subjected to. We also have a model of regional normothermic reperfusion. This is something that we see actually in the clinic in certain types of donors. And we also have modeled brain death, very close to that what is found in the patients with at least 4 hours of care after brain death. Then the organs are collected, cold stored, either with machines or with static, the same machines that are used in the clinic, and then transplanted, most of the time in the same animal, because we only study ischemia reperfusion and not the allo reaction that we can find in the clinic. And then in terms of follow-up, we have 3-month follow-up, which allows us to have, during the first couple of weeks, the immediate recovery of function, but also at the end of the 3 months, we can see what happened in terms of chronic damage, such as fibrosis and loss of function. This is quickly what the lab looks like. Some of the surgical apparatus, and that I take the word for granted personally, I'm not a surgeon, but when surgeons come to operate here, they're very happy because it reminds them exactly of what's in their home hospital. And the piggy sits in a metabolic cage that is specially designed for it, so we can collect urine and actually have the biochemical metrics. Now, in terms of what we did concerning the mitochondria, we studied 3 different compounds over the years, and I'm now going back to it. So I'm going to present you the result from the trimetazidine experiment, the TSPO and the GC7. Now, trimetazidine is a compound that has been described to have 2 different functions. One of them is a proton shuttle, so it can shuttle proton from one side of the membrane to the other. And the other is a metabolism direction effect when it can favor the glucids use for energy metabolism rather than the lipid use. What we know is that, when we tested it in our preserved organs for varying length of time, the first thing that you see here is this is electron imaging of kidneys that have been preserved in 2 different preservation solutions for 24 hours, 48, and 72 hours. You can see that the mitochondria is not doing very well. It's not handling that kind of stress very well. Whereas when we use trimetazidine, we can actually preserve the density of the mitochondrial matrix, its organization, and its different inner membrane. I lost the word, but anyway. So the density is directly linked to the ability of the organ to recover its function post-transplantation. We can actually recover function even after 72 hours preservation, which is actually unheard of in terms of using standard preservation solution. And this has allowed us to do a few studies in isolated perfused organ as well as auto-transplantation. Now, in terms of PBR or TSPO, this is translocator protein. It is described as being part of the transport of cholesterol into the mitochondria in steroidogenic organs. Now, it actually is detected in the kidney, which is not a steroidogenic organ, particularly in the distal tubules of the kidney, where only after an ischemia reperfusion injury, we find it in the proximal tubules of the kidney. One hypothesis is that the damaged cells are being replaced by cells coming from the distal tubules, going up the nephron to regenerate. What we know for sure is that it is expressed in the proximal tubules of kidneys that will recover function better. That is a low level of ischemia reperfusion injury. So it can be used as a marker of better regeneration, so a marker of quality for these organs, but also being used as a target to promote better regeneration within the organ. What we also know is that it is not the multimeric TSPO that's actually working, because when we overexpressed it in cells and allowed those cells to better survive the stresses of ischemia reperfusion, they increase production of monomeric TSPO and not multimeric TSPO. So in terms of its mechanisms, we don't know for sure. What we do know is that it does preserve mitochondrial architecture and improve ischemia reperfusion resistance. The last compound that I will be talking about in terms of the mitochondria is GC7, which we recently used. This is a spermidine-like compound that has been described as being able to shut down the mitochondria for a period of time. You can see here that using it on mitochondria permits us to decrease the level of expression of complexes 1, 2, and 3, as well as their function. So it simply puts the mitochondria in a dormancy state. And when we used it on our pigs, when we pre-treat the pigs and treat it for 2 time points, 24 hours and 3 hours before collection, we then collect the kidney, preserve it for 24 hours in the cold, and transplant it in the same animal. What we see is that when we use GC7 here with the little circles, we have a lower curve in creatinemia compared to vehicle-treated animals. What does that mean? The fact is that creatinemia is normally filtered by the kidney. That is, if you have it in your blood above a certain point, obviously, your kidney is not working very well, especially the glomerulus too, but I don't really want to go into details right now. So what we see is that we have lower level of creatinemia, and very interestingly, we actually recover levels that were found pre-transplant. What's very interesting is that pre-transplant, the organ at the pig had 2 kidneys, whereas after transplantation, we remove the other kidney. So this is only one kidney doing all the work, and it's actually doing it very well. And when we look into that kidney, when we checked for signs, this is in the vehicle treated. The red here is fibrosis, tissue fibrosis. It's basically the scar tissue that replaces the functional tissue. Normally on the skin is just a scar. However, in the kidney, the scar tissue cannot filter and make urine, so it's a bad thing to have. So the more you have in red here, the worse your kidney is going to be. And we see that in GC7, we have levels that are hardly distinguishable from the control group here. Control group is simply an animal that has been living off of one kidney for 3 months. Now, recently, we've been going back to the cell model and taking interest into the effect of cold ischemia time on cellular mechanisms, going a little bit far away from the mitochondria, but not too far. We went to the endoplasmic reticulum, which is actually linked to the mitochondria through the MAMS. And we studied ER stress in response to cold ischemia time. Now, ER stress signals through 3 different pathways: the PERK ATF4 pathway, the ATF6 pathway, and the RA1 alpha XBP1S pathway. And we wanted to detail the role of each of these pathways during cold ischemia to see if, first of all, there was a different role for each one of them, and if they were linked to cell survival. So the first thing we did is measure their import into the nuclei, because each of them is a transcription effector. So we did electromobility shift assay to detect the arrival of the ATF4, for instance, here in the nuclei. We saw that it did translocate to the nuclei in the first hours of the cold ischemia. This is cold ischemia time here: 0 hours, 6 hours, 12 hours, 24 hours of cold ischemia on the cell. This is in an anoxic atmosphere with the solution that is used for organ transplantation. So it does mimic what we found in the organ as close as we can get, obviously. So interestingly, we have an import of ATF4 at the beginning of preservation, and when we activate ATF4, that is that we maintain this import, this activation for the whole duration of cold ischemia, we increase cell survival. This is simply cell survival here. In control condition, control plus condition, the ischemia reperfusion, we lose about 50 to 60% of cells, and when we activate the PERK ATF4 pathway, we restore cell survival all the way to the level of the control, which has not been subjected to cold ischemia. So ATF4 appears to be induced early in the cold ischemia time, and when it is overactivated, it can improve survival. This would appear to seem that ATF4 would be linked to short cold ischemia time, which is actually something that the cell can pretty well handle. Now, ATF6, we saw its import later during preservation. This was confirmed by Western blot, and since it was later, we figured maybe it's associated with the worst outcome for the cell, so let's inhibit it. So we inhibited ATF6 production with ABSF, which is a pharmacological approach. We also did the same thing with siRNA, and we saw every time when we inhibited that pathway, we improved cell survival. So here also we have a pathway that is linked to cold ischemia time, this time extended cold ischemia time, usually linked to worst outcome. And indeed, when we inhibit it, we find that we improve survival. And the last pathway is XBP1, RA1 alpha XBP1S. We actually saw XBP1 production only at reperfusion, but in cells that were subjected to at least 8 to 12 hours cold ischemia time. So this was indirectly related to cold ischemia time. This is one of its targets, which we saw indeed at reperfusion, and only on those stressed cells. And indeed, when we inhibited the production of XBP1S, we could see improved survival. So again, this is another pathway that is linked to cell death in cold ischemia, extended cold ischemia time, which can be acted upon to protect the cells. So the next part of the talk, probably in the next few years, is to go back to the mitochondria from the ER and study another phenomenon that can be very interesting, is mitochondrial dynamics. Here you have schematics of mitochondrial fission. We also will be studying fusion and reorganization of mitochondria during cold ischemia time, because it appears that a lot of things are going on during cold ischemia, which on one hand is actually surprising. It's supposed to be a stasis if you listen to surgeons 30 years ago. But actually things are going on, and if we monitor them, we can actually check the quality of the organ with time, and maybe we can act upon them to improve this quality over time. Thank you very much for your attention.
I just have one question about trimetazidine.
Mm-hmm.
Since it's a mild uncoupler, as you have shown,
Yeah.
did you check the hydroperoxide production in these cells or something?
That I'm afraid, the problem with trimetazidine is that it happened before my time, before I joined the lab. Okay. I do believe that hydrogen peroxide experiments were conducted at the cellular level, and we saw an actual decrease of radical production, but maybe not at the state of intracellular matrix and cytosol discrimination, but we did see lower oxidative stress.
I have a question also using trimetazidine or GC7.
Mm-hmm.
So do you give them during the ischemic phase or during the reperfusion or even before the surgery? How is it delivered?
The GC7 here was given before organ collection, which is not, it's not compatible with transplantation itself, but it was a proof of concept. We are thinking right now of giving it during donor management. So once the donor is proven to be an organ donor, you still have a few hours before organ collection on which you can act upon the organ. Before that, it's not allowed because you will be treating the patient. So GC7 needs to be there before cold ischemia, so that's one of the limits of that compound. However, trimetazidine, we simply used it in the flush and in the preservation solution. So that's much easier. You just pop a syringe in the bag and then flush the organ and preserve it in the same thing.
And what is the clinical use of this drug? Is it something used routinely during heart transplantation, or because
unfortunately, a lot of the molecules that are been proven to be effective even on large animals are still not used in the clinic. One of the reasons is that, let's see, 15 years ago, when my boss sent a paper to one of the big journals in the transplantation, they sent it back saying that ischemia reperfusion is not a problem in transplantation. So we are slowly but surely getting people interested in the fact that preserving your organ better might improve transplantation. So it's getting there, but not as fast as we'd like.
Thank you.
Sorry, so I forgot the name of the molecule, but you mentioned a molecule that can transport protons or uncouple and at the same time modulate glucose consumption. Can you say more about this molecule?
That's trimetazidine. Unfortunately, the mode of action hasn't been disclosed to us all that much. That's one of the problems when you work with the industry. They tend to keep quite a few cards to their chests. They told us that it does act as a proton shuttle, and it does redirect the glucose metabolism towards glucose use. However, more than that, I simply don't have the information, unfortunately. But it is very frustrating for us too.
Just about JC7, you show that there is decreased complex 1, 2, 3. Mm-hmm. Do you know by which mechanism you end up decreasing these complexes?
Not yet. This is a new molecule, actually. The paper that on the proof of concept was just published this year. And in terms of mechanisms, is going to be one of the challenges that we have to face, a very interesting challenges, because it's a spermidine-like, spermidine and spermine participating to a lot of different effects and signaling pathway within the cell. So I don't know yet how it works, but it could be very interesting to know, yes.
Okay. Yeah.
Thank you very much.